Welcome everyone to Retina Synthesis. I'm Dr. Carmen Pugliafito, and I'm joined here today once again with Dr. Alan Ho, who is Professor of Ophthalmology at the Thomas Jefferson School of Medicine and Director of Retina Research at the Wills Eye Hospital. Alan, welcome back to Retina Synthesis.
Good to be back.
At the last subspecialty day meeting of the American Academy of Ophthalmology, you gave a great talk about optogenetics and the initial results from the Nanoscope clinical trials. Can you tell us what optogenetics is and why we should be interested in it?
Sure, Carmen. The optogenetics is really in its second iteration. There are initial attempts at optogenetics, and what it means is using gene therapy-like strategies to reanimate residual retinal cells. So, for example, in patients with retinal degenerations, the myriad causes of retinitis pigmentosa and retinal degeneration, loss of photoreceptors, loss of the native opsin, the light-sensitive molecule in rods and cones, rhodopsin. Um, Optogenetics aims to create light-sensitive molecules, for example, a transgene encoding for a bioengineered light-sensitive molecule, a biosynthetic opsin, and then using, let's say, an AAV2 vector to transfect residual retinal cells. Optogenetic strategies that have been tried in the case of retinitis pigmentosa and retinal degenerations have aimed to transfect ganglion cells or bipolar cells. In this particular program, we presented the 3-year results of the Nanoscope optogenetic program, MCO010, a bioengineered synthetic opsin that aims to reanimate bipolar cells, specifically on bipolar cells, as opposed to off bipolar cells. And using this particular next generation bioengineered opsin, the reason why I'd call it next generation is because, one, it's visible light wave sensitive as opposed to requiring amplification with goggles. Number two, the kinetics of the MCO010 bioengineered opsin are fast on and fast off, which is important if you think about potential vision reanimating residual retinal cells for an object that is in motion. You need on and off pretty fast. And three, this particular opsin is sensitive across visible wavelengths for example, a stoplight. You could see red, green, and yellow. Opsins are, we're familiar with rhodopsin, but opsins are, in general, light-sensitive transmembrane proteins. And we think about rhodopsin for light and vision. There are other opsins. So rhodopsin is a member of a family of opsins in the body. There's melanopsin, skin cells, hair cells, neuropsin, retinal cells that control other functions other than vision. For example, circadian rhythms, sleep-wake cycles, hormonal release. So opsins are light-sensitive molecules. Rhodopsin, one example, MCO010, an example of a bioengineered next-generation opsin, neuropsin, melanopsin, that uses light to signal some neurologic function. And it's not only vision. This program, I think you need to pay attention to because we're in a gene therapy era. Gene therapy started in the subretinal space. Thank you, Gene Bennett and Al McGuire over at Penn, right across the river from us, using a gene replacement strategy for Leber congenital amaurosis, RPE65 mutation, a specific retinal degeneration, a small sliver of the array of mutations that cause retinal degeneration. You have that defective gene, introduce the functional gene and created vision. And kids around the world have benefited from that strategy. Since that time in 2017, there have been about 30 to 40 gene therapies approved across all of medicine. So I think this is relevant because we're now bringing gene therapy back to the retina and bringing it back to a group of patients that are, the most needy of all. In your career and my career for 25 to 30 years, I've been trying to avoid creating false hope in these patients. And now with the data that we presented, I think there's reason to believe for some real hope. FDA submission is rolling, fast track, orphan disease, expedited, and the initiation of the application has started this year. It will continue into 2026, and hopefully we'll have some US FDA assessment of this data set.
So one exciting thing about optogenetics is that it is not specifically replacing any gene. So retinitis pigmentosa is caused by hundreds of genetic defects. So this is uh, oblivious to genetic defects, those gene-specific defects.
Exactly. So it's mutation agnostic. You lose your photoreceptors, you lose your native rhodopsin. This aims to bioengineer and reanimate the retina, for example, residual bipolar cells. And we know there are some residual bipolar and ganglion cells in these retinal degenerations. It's also not just mutation agnostic, but kind of diffuse retinal degeneration or macular atrophy, macular degeneration, Stargardt's macular disease, potentially AMD, GA agnostic. And in fact, in a preliminary Stargardt's macular atrophy trial, those with a certain phenotype, that is, without the diffuse degeneration in more the macular atrophy, had a signal of some improvement in visual function. So it is mutation agnostic for RP, those most needy patients that we've had for my entire career, your entire career. And I think it provides some hope, but also looking at it for potentially improving central vision in those with central macular degenerations, age-related or genetic, like Stargardt's. We
So
shall
tell us
see.
about the results.
The results of the retinal degeneration trial were phase 2b/3, multi-center, randomized, sham-controlled clinical trial. Three randomization groups: a sham injection, a low dose, and a high dose, MCO 010, and it met its primary endpoint at 52 weeks, with 45% of subjects having a 0.3 logmar or 3-line visual equivalent gain in vision, statistically significantly improved over sham in both the high and low dose. And at 76 weeks, again, that 3-line vision improvement was held at 72 weeks. And at 3 years, the 0.3 logmar or 3 lines of vision was also maintained. Now, these were a group of patients that were off chart. They were bare hand motions, light perception, bare light perception, even a couple NLP, no light perception subjects were enrolled. And the standardized chart is with this kind of visual ultra low vision testing is called the Freiburg Visual Acuity Testing Chart. It's been independently validated. And these results held out to 3 years. If you looked at the visual acuity curves, you'd see the high dose and low dose with improvements in vision, not just think about it, not just a reduction in decline of vision, but actually improvements in vision that were sustained out to 3 years compared to sham. And this is the basis of the efficacy data. The safety data look really good. 3-week oral course steroids in the beginning with a one-time injection. This is all one-time injection, no repeat injections. Intraocular inflammation was observed in some of the patients and was controlled with topical drops. Specifically, none of the bad serious adverse events, no retinitis, no vasculitis, no choroiditis, no optic nerve uh, issues, no hypotony, none of the bad things we've seen in other intravitreal gene therapy um, programs. So that's the basis of it. Clinically meaningful, one-time, mutation agnostic, durable vision improvements that are meaningful to patients out to 3 years. It's like, to give you an example, some of the patients were barely hand motions to going to on-chart vision. One of the guys was a climber and he could rock wall climber in a gym, and he could wind up seeing things and seeing the colors of the hand grips that he was grabbing. Not every patient responded though, and we need to do more work on some of those. Some didn't respond at all, but 40% had 45% at 52 weeks had 0.3 logmar, and 55% at 72 weeks, the key secondary endpoint, had zero point 0.3 logmar improvements.
So what was the best vision that was achieved?
One patient went better than 2200 from off-chart vision. There
Hmm.
were multiple patients that went to 2400 and 2800.
So what's the next step?
The next step is in that program is um, completing submission of the biologic license application, which is multiple components of the preclinical work, the clinical work I just described, and then the manufacturing ability that you can show you can commercialize and scale this up. So that's ongoing, and that submission should be in sometime in the beginning of 2026 complete. Right now, we're waiting for some manufacturing. Um, Basically, got to be able to bake the cake over and over again and scale up production.
Do they need to do a larger scale clinical trial?
Maybe not. Maybe not. To give you perspective, um, Argus for ultra low patients, that was a device, was about 30 subjects. Um, Luxturna Spark was about 30 subjects. This is about 30 subjects. It was 27 subjects, 9 in each group. Um, and I suppose that could be a response, but that's for this type of ultra low patient population, it hasn't been required before. Next steps also, Stargardt's disease is going to continue to its next phase. And excitingly, from my perspective, AMD geographic atrophy study startup process has begun for that.
So in geographic atrophy, are bipolar cells preserved?
Some of them are preserved, yes. In AMD GA, you'll see some bipolar and ganglion cells preserved.
Because usually, what happens to the OCT in these patients?
Thinning, like
What?
a lot of some of the patients in the program that I discussed for the retinal generations, and they took all comers, some that had been, blind for years. There was thinning. More work needs to be done to figure out who the responders are and if we can predict who the responders
Mhm,
will be.
mhm. So what dose are they using, the low dose or the high dose?
Both doses are pretty close, so we'll see. High dose did a little bit better.
What about nanoscope approach in contrast to the approach using goggles?
Yeah, the goggles, I think we're part of another optogenetic program that didn't have the visible wavelength sensitivity that this particular nanoscope bioengineered opsin has. And so sometimes you have to enhance the signal for some opsins, and I've seen that for other programs.
Mhm.
Not required for this one.
Well, Alan, thanks so much for sharing this exciting news on optogenetics. It, it sounds promising.
I think there's reason for some real hope, and we shall see. And thanks for the time to be here.
Thank you.